Anemia is simply too little oxygen carrying power in the blood. Find the missing ingredient, iron, B12, or folate, and you found the answer. Welcome to our review of anemia. 10 questions covering the types, the classic iron and B12 pictures, medications, diet, and nursing care, including transfusions. Pause when I tell you, choose your answer, then check yourself. Let's go. Question 1. RBC morphology. A nurse is reviewing the characteristic red blood cell changes seen in iron deficiency anemia. In iron deficiency anemia, the red blood cells characteristically appear: A. Large and pale in color, macrocytic. B. Normal in size and color, normocytic. C. Small and pale in color, microcytic and hypochromic. D. Rigid and sickle-shaped, crescentic. Pause and choose. The answer is C. Small and pale, microcytic and hypochromic. Iron is needed to make hemoglobin, so when iron is low, red cells are made small and pale because they carry less hemoglobin. That's why iron deficiency anemia is classically a microcytic hypochromic anemia, confirmed by a low MCV on the blood count. Large macrocytic cells point to B12 or folate deficiency instead, and sickle shapes indicate sickle cell disease. Let the cell size sort the cause. Microcytic means iron deficiency, macrocytic means B12 or folate, and normocytic points to acute blood loss or chronic disease. Question 2. Identifying the type. A 34-year-old woman comes to the clinic reporting several weeks of fatigue, weakness, and breathlessness on exertion. She has heavy monthly menstrual periods. On examination, she is pale, with brittle spoon-shaped nails and a smooth, sore tongue. Her labs show a low hemoglobin, a low MCV, and a low ferritin. Which type of anemia is most consistent with these findings? A. Iron deficiency anemia. B. Pernicious B12 deficiency anemia. C. Folate deficiency anemia. D. Aplastic anemia. Pause and choose. The answer is A. Iron deficiency anemia. Everything points to iron deficiency. A low MCV, meaning microcytic cells, and a low ferritin, meaning depleted iron stores, are the giveaway labs. Chronic blood loss from heavy menstrual periods is the classic cause in a woman of this age. The spoon-shaped nails, called koilonychia, and the smooth, sore tongue, called glossitis, are hallmark physical signs of iron deficiency. B12 and folate deficiency give a high MCV, not low, and aplastic anemia lowers all blood cell lines and wouldn't fit an isolated low ferritin. Low ferritin plus low MCV plus heavy periods equals iron deficiency. Question 3. Iron supplements teaching. A 28-year-old woman is prescribed oral ferrous sulfate for newly diagnosed iron deficiency anemia. The nurse teaches her how to take the tablets for the best possible absorption. Which instruction is correct? A. Take each dose with a full glass of milk at bedtime. B. Take it together with your usual antacid tablets. C. Take it with a large bowl of high-fiber bran cereal. D. Take it on an empty stomach with a glass of orange juice. Pause and choose. The answer is D. Take it on an empty stomach with a glass of orange juice. Oral iron is best absorbed on an empty stomach, and vitamin C, as in orange juice, further enhances absorption. If the empty stomach causes stomach upset, it can be taken with a little food, though absorption is somewhat reduced. Milk, antacids, high-fiber foods, tea, and coffee all reduce iron absorption and should be separated from the dose. A few more teaching points. Expect dark or black stools, which are harmless. Constipation is common, so encourage fluids, fiber, and activity. Use a straw for liquid iron because it stains teeth. And keep iron away from children because overdose is toxic. Question 4. Pernicious anemia. A nurse is explaining pernicious anemia, which develops when the stomach cannot produce intrinsic factor. A lack of intrinsic factor prevents the absorption of which vitamin? A. Vitamin C, ascorbic acid. B. Vitamin B12, cobalamin. C. Folic acid, folate. D. Vitamin K, phylloquinone. Pause and choose. The answer is B. Vitamin B12, cobalamin. Intrinsic factor is a protein made by the stomach's parietal cells, and it binds vitamin B12 so it can be absorbed in the terminal ileum. In pernicious anemia, an autoimmune condition, the parietal cells are lost, so intrinsic factor is missing and B12 cannot be absorbed. The result is a macrocytic anemia plus neurologic signs like numbness and tingling and a beefy red sore tongue. Remember the chain: no parietal cells, no intrinsic factor, no B12 absorption, and therefore pernicious anemia. Because the gut can't absorb it, B12 has to be replaced by injection, not by oral iron or folate. Question 5. Managing pernicious anemia. A 60-year-old man with pernicious anemia has numbness and tingling in both feet and a beefy red sore tongue. He asks the nurse how his condition will be managed over the long term. Which is the nurse's best response? A. A daily oral iron tablet will correct the problem. B. A short course of folic acid will cure the condition. C. You will need lifelong vitamin B12 injections for this. D. Regular blood transfusions will be your main treatment. Pause and choose. The answer is C. You will need lifelong vitamin B12 injections. Because the gut cannot absorb B12 without intrinsic factor, oral B12 is unreliable, so B12 is replaced by intramuscular injection. Treatment is lifelong, often monthly injections after an initial loading phase because the absorption defect is permanent. Correcting the B12 resolves the anemia and can halt, though not always reverse, the neurologic symptoms, so early treatment matters. Iron doesn't fix a B12 problem. Folic acid can mask the anemia but doesn't correct the B12 deficiency or the nerve damage. And transfusion isn't the routine treatment. B12 replacement is. Question 6. Dietary iron. A nurse is teaching a patient with iron deficiency anemia about good dietary sources of iron. Which food would the nurse not recommend as a good source of iron? A. Lean red meat and liver. B. Dark green leafy vegetables. C. Beans, lentils, and fortified cereals. D. Milk, cheese, and other dairy foods. Pause and choose. The answer is D. Milk and dairy, which is not a good iron source. This is a negative STEM item, so we're choosing the food that is not a good source of iron. Milk and dairy foods are poor in iron, and the calcium in them actually reduces iron absorption, so D is the food not recommended for iron. Good iron sources are red meat and liver, which contain heme iron that's best absorbed, plus dark leafy greens, beans, lentils, and fortified cereals, which contain non-heme iron. Pair plant non-heme iron with vitamin C to boost absorption. Question 7. Severe anemia priority. A 70-year-old man is admitted with a hemoglobin of 6.5. He reports dizziness and marked shortness of breath. His skin is pale and his heart rate is 118. Which nursing action is the priority? A. Give oxygen and prepare for the prescribed blood transfusion. B. Encourage him to walk in the hallway to build strength. C. Restrict his oral fluids to lower the cardiac workload. D. Provide a large, high-fiber meal to boost his energy. Pause and choose. The answer is A. Give oxygen and prepare for the prescribed blood transfusion. A hemoglobin of 6.5 is severe anemia, and with dizziness, dyspnea, pallor, and tachycardia, the body is struggling to deliver oxygen. The priority is to support oxygenation now. Apply oxygen and prepare for the prescribed transfusion to restore oxygen carrying capacity. The fast heart rate is compensatory, the heart pumping faster to make up for the low hemoglobin. Ambulation increases oxygen demand and is unsafe here. The patient needs rest. Fluid restriction doesn't treat anemia, and a meal doesn't address acute symptomatic hypoxia. Question 8. Transfusion reaction. 15 minutes after a blood transfusion is started, a patient suddenly develops fever, chills, flank pain, and dark colored urine. The nurse suspects an acute hemolytic transfusion reaction. What is the nurse's first action? A. Slow the transfusion rate down and keep observing him. B. Stop the transfusion and keep the line open with saline. C. Give an antipyretic and let the transfusion continue. D. Wait for the unit to finish, then notify the provider. Pause and choose. The answer is B. Stop the transfusion and keep the line open with saline. Fever, chills, flank or back pain, and dark urine signal an acute hemolytic reaction in which the transfused cells are being destroyed. It's life-threatening. The first action is always to stop the transfusion immediately, then keep the IV line open with normal saline using new tubing to maintain access and support the kidneys. After that, notify the provider and the blood bank, monitor vital signs closely, and return the blood and tubing per policy. Slowing the transfusion or giving an antipyretic and continuing both keep the harmful blood flowing, and waiting for the unit to finish is dangerous. Question 9. Iron absorption. A nurse teaches that one substance taken together with oral iron improves how much iron the body absorbs. Which substance best enhances the absorption of oral iron? A. Vitamin C, ascorbic acid. B. Calcium carbonate supplements. C. Aluminium antacid tablets. D. Strong tea or coffee. Pause and choose. The answer is A. Vitamin C, ascorbic acid. Vitamin C keeps iron in the form the gut absorbs best, so it enhances the absorption of non-heme and supplemental iron. That's why oral iron is often taken with orange juice or another vitamin C source. By contrast, calcium, antacids, and tea or coffee, which contain tannins, all reduce iron absorption, so separate them from the iron dose. Think boosters versus blockers. The booster is vitamin C, and the blockers are calcium and dairy, antacids, tea, coffee, and high fiber or whole grains. Time the dose away from the blockers to get the most iron. Final question. Iron therapy follow-up. A patient who started oral ferrous sulfate 2 weeks ago returns for review and is worried because her stools have turned black. She reports no abdominal pain and her vital signs are normal. Which is the nurse's best response? A. Stop the iron at once. This is dangerous bleeding. B. This shows the iron tablets are not working for you. C. Black stools are an expected harmless effect of iron. D. You should double your iron dose from now on. Pause and choose. The answer is C. Black stools are an expected harmless effect of iron. Oral iron normally turns the stool dark green to black, and this is a harmless expected effect, not a sign of bleeding. Reassure the patient and encourage her to keep taking the iron as prescribed. Also teach that constipation is common, so increase fluids, fiber, and activity, and that stomach upset can be eased by taking iron with a little food. Know the difference between expected and worrying. Dark stool, mild upset, and constipation are expected, but severe abdominal pain, vomiting blood, or truly tarry, sticky, foul stools with dizziness should be reported because that could mean gastrointestinal bleeding rather than just the iron. Subscribe for a new set every week and share this with a classmate because we don't pass alone, we pass together. See you in the next one. Those are your 10 anemia concepts. Iron deficiency gives microcytic hypochromic cells. A low ferritin with spoon nails points to iron deficiency. Take oral iron on an empty stomach with vitamin C. Pernicious anemia is a lack of intrinsic factor blocking B12. It's treated with lifelong B12 injections. Milk and dairy are poor iron sources. Severe anemia needs oxygen and a transfusion. For a hemolytic reaction, stop the transfusion and run saline. Vitamin C boosts iron absorption, and black stools with iron are harmless. Subscribe for a new set every week and share this with a classmate because we don't pass alone, we pass together. See you in the next one.